Okay, welcome everybody to this edition of the Drive to Deprescribe webinar series. My name is Chad Wers. I'm the Chief Executive for the American Society of Consultant Pharmacists, and I am a long-term care pharmacist by background. And today we're going to be talking about optimizing the use of arthritis medications, brought to you by the D2D and AMDA team. And this session is going to address the medication use and deprescribing for gout and arthritis, behavioral interventions to consider, and patient, provider, and caregiver challenges and how to overcome them. And just to give you a story, I think just to set this up, arthritis and gout is not always the most provocative top of mind topic for us when we're talking about medication management. But I used to do a radio show in Cincinnati, and it was an Ask Your Pharmacist type radio show with a partner of mine. And I'll never forget, it was right around the time that Vioxx, an old COX-2 inhibitor, was being pulled off the market, and having to field phone calls from people that had tried all kinds of medications for their arthritis and only found that Vioxx was worked for them. And it just underscores the fact that we work with a population that is sensitive to medications, and that when we find the right medications for them, sometimes it's, very individualized and there aren't great options. So I was just struck by that particular episode where this person felt like they had nowhere to go now that we were pulling the Vioxx off the market, and she had tried all these other medications and they hadn't really worked. So this promises to be a very informative discussion. We have a great speaker for today. Barbara Resnick is currently a professor in the Department of Organizational Systems and Adult Health at the University of Maryland School of Nursing, has over 40 years of clinical experience as a nurse practitioner across all settings of care. Her research program is focusing on optimizing function and physical activity amongst older adults, exploring resilience and genetics on function and physical activity, and testing, dissemination, and implementation of interventions in real-world settings. She's an active member of AMDA, the Society for Post-Acute Long-Term Care Medicine, and is the current chair of the Society's Assisted Living Subcommittee. So without further ado, I will turn it over to Barbara.
Yeah, hi, and it's a pleasure to talk to you all. I don't know, this might be a little different than some of the other talks, because with pain and pain management, when we talk about deprescribing, some of the issues may be a little different. I'm going to tell you a little story too. I'm currently in the process of testing the implementation of the new pain clinical practice guideline, and I'm finding in many ways what I do more than anything is deprescribe some of these meds, and I'll be sharing some of that. But let's start with gout, which is in the arthritis family. And, it's an interesting thing with gout because the treatment focus is basically on decreasing uric acid and preventing acute attacks with the intention of managing pain. So we traditionally acutely treat with colchicine, non-steroidals, sometimes glucocorticoids, and then chronically treat with xanthine oxidase inhibitors. What happens, I find, for many older adults is treatment may have started sometime in middle age and then continues forever. People hold on to it. Patients, families totally fear if we stop any of these, the world's going to fall apart. And often with age, many of these people are now on more controlled diets. I'll say they're not getting the foods they might have been eating before or the drink that they may have been drinking before. And they've also possibly lost a good bit of weight. Many times I find they can't even remember the last time there was an event. So very much with gout, we need to take it as a case-by-case approach. How frequent are these attacks? Is there any evidence at this point of gout? I've seen people who have a terrible tophus, inflammation and drainage, and it's chronic. Those people may want and need to continue, but no attacks that can be remembered. That's when we want to begin to think about deprescribing. And if you are going to decrease the xanthine oxidase inhibitors, we do recommend doing that over time to prevent or monitor for rebound. It's also, I find, a nice assurance for patients. They don't like to stop anything right away, but are sometimes willing to decrease. Non-steroidals, this might be my bias, but I'm like, I have seen too many bad things happen over the years. I don't care if I've seen people go into renal failure with one dose and spend the rest of their lives on dialysis, and people long-term having bleeds. We all have our stories. So I say stop as soon as possible. Colchicine can be weaned down if people take it regularly, or stop it and just use that truthfully should only be used short-term. Let's talk now a little bit about what's probably one of the most ubiquitous medical problems for everybody as we age. I could almost say 40 and above, because it really starts then, but certainly for people we see in their 60s and above. And it really varies how bothersome it is in terms of intensity and inflammation. It's often chronically treated, and people use anything from acetaminophen, non-steroidals, steroids in some cases, opioids in some cases. And then for rheumatoid arthritis, we know there's also the use of NSAIDs, steroids, opioids, and DMARDs, either conventional or targeted. Again, a case-by-case approach is needed. You need to evaluate the pain and the impact on daily life, and then consider decreasing meds over time. And it's really, you know, I hope if nothing else, today's talk increases awareness to think about maybe stopping these drugs. If working with a rheumatologist, sometimes we have to talk about the cost benefit of the med for the individual. I always remind people there is no perfect magic drug to relieve pain that has no side effects. And I don't know if you can see the cartoon, but we combined all of your medication into one convenient dose. Even that great big dose doesn't do it. And everybody wants that perfect pill. So I want to take a few minutes now and think a little bit more about pain assessment, pain diagnosis, and pain management, because it really is relevant to deprescribing. So there's a lot of definitions of pain. Pick your favorite. You know, everybody has their own, and everybody reacts to a pain stimulus differently. I'm sure you have all seen those patients that when you check their blood pressure, you would think you were committing some kind of horrible treatment to them. And it's a squeeze for a minute or a blood draw. So it's really getting a sense of how that person defines pain, what it is to them. The impact of pain also needs to be thought about. There's many risks to undertreatment. We become cranky. Some people curl up into a ball. Some get depressed. Some want to hit everybody in their path. And some people want to dive out a window. And some people do dive out a window. It can cause a reduce in function. If it hurts, people won't use it. It results in drug-seeking behavior. It can result in increased morbidity and mortality. And there's certainly survey-related issues, lawsuit-related issues, and high use of either a healthcare provider or emergency room. Many people will go for pain. Optimal treatment is our goal. And the goal is to really optimize function, which is critical for older adults, and certainly quality of life. People should be able to control the pain, to do the things they want to do in the course of the day. I never promise anyone I'm going to make it all go away with no drug side effects, right? The risk of over treatment is also critical. That can have an impact on mood and behavior, can also make people aggressive, can also cause confusion, psychosis. My biggest concern with over medication is the whole issue of sedation. We can put people to sleep with drugs. They may not have pain, but they won't eat, they won't drink, they won't move, and we know what happens. And then certainly there's the issue of survey deficiencies related to treatment and also excessive polypharmacy. What are some of the challenges? I'm sure you all know them, but the challenges with assessing pain are, can somebody even tell us they're having pain? Will they tell us? Can we see it? Do we look for it? Do we look for the underlying cause? When was the last time you took a minute and really delved deeply into what was causing the pain versus just jumping right away to treatment? Because you got a call at 10 o'clock at night, Mrs. Jones is having pain, what can I give her? And we never step back and say, well, what's causing the pain? I just treated a pain in the pain study, actually, where the poor individual had a stroke, had a contracted hand, and his fingernails were digging into the tissue of his hand. And I quite simply cut his nails. He was the happiest man in the world. It's that simple, but if you don't take the time to look, not rocket science, but sometimes we can really find that cause. Because there is no perfect pain solution, identifying the underlying cause is critical. When should we evaluate pain? Well, one of the things that drives me crazy is people always just ask when somebody is comfortably sitting in a chair, totally braced, not moving a muscle, are you having pain? Well, no, if I don't move anything, but the second I stand up, it hurts like hell everywhere. So I really recommend getting an assessment of pain in different positions. If somebody is not a functional ambulator, you can often get them to stand and see what happens. If somebody is in bed, they can do bed mobility. We can help with bed mobility, and you just have to watch the face and you'll see that there's pain. And I teach advanced practice nurses, and one of the hardest things I have is getting nurses to cause pain to a patient, because their whole nursing degree is based on relieving pain. And sometimes we have to cause it to make that diagnosis. And then document what the resident is doing at the time of evaluation, and asking them to describe, if they're able, what their pain is. And often, I don't know if you've ever had pain, but I'm sure many of you have had that pain where you really do want to say, could you kill me now? Some pain assessment tools, if you have to observe, observation tools are recommended, particularly for people with cognitive impairment who can't express it. I still say always ask, and ask while you're having the person move and trying to engage them. If they can respond verbally, there's verbal response scales, whether you use a 0 to 10, 0 to 5, whatever's your preference. If you do have to use an observation scale, I find the Pain AD is one of the quickest and easiest ones to use. It goes through some common behaviors we see when people have pain. Breathing heavily, it might be negative vocalization, calling out, groaning, not rocket science. If it hurts, people scream. Some people, as I said, curl up in a ball and become very quiet. Facial expression, often you can see whether it's grimacing, but you'll see a reaction on somebody's face. Body language, people tense up, they pull up their knees and pull up into a ball. Again, everybody has their own way of responding to pain. And then consolability. Do they need to be distracted? They're so distressed by that pain. They need you to jump in and do something. Some other factors to consider and document as possible indications of pain, particularly over a longer term, would be things like people not engaging in activities anymore, a change in gait, watch that gait, or people's refusal to walk or to transfer. Fidgeting, frowning, some of the facial expressions, increased agitation, increased resistance to care. If it hurts when you move that arm and you're bathing somebody, they're going to hit you. And then any type of social withdrawal or increased depression. Again, these are the recommended scales, whether it's a verbal scale, if somebody can complete it. If you're in nursing homes, certainly there's a MDS option. This is just a form that we use to do some additional questioning about pain, some guidance to help you go back to kind of physical assessment 101 and ask some of those questions about pain. And it's amazing, even from people with cognitive impairment, what you can learn. Good assessment results in successful management. It's really the key. As I said at the beginning, there is no perfect drug. There's different definitions of pain. It can be acute, it can be chronic, neuropathic, or nociceptive. Acute pain, you all know, really starts suddenly, and it's usually because something's happened, either acute tissue damage, something happened, fracture, that kind of thing. Chronic pain typically lasts more than 3 to 6 months, and you may not really find a particular incidence. And we think of this more as arthritic pain. Neuropathic pain can either be acute or chronic if there's acute compression on a nerve. We tend to think of it more associated with diabetic neuropathies. Post-herpetic neuralgia is also another common one. It's often described as burning and stabbing and shooting, but not always. And again, some people can describe it well, others not so much. Nociceptive pain implies that there was some type of tissue injury, might have been a broken bone or inflammation in an organ such as appendicitis. Now, all of us who do geriatrics know most older adults who present with appendicitis don't tell you anything about pain. They just vaguely haven't felt well for a day or two, may have some constipation. So it's a tough one. But if they do have that nociceptive pain, it certainly is a help for making that diagnosis. So pain could be anything from due to medication, due to trauma, due to acute exacerbation of an underlying disease like arthritis, or inflammation. Think about those mouths, think about those feet. It's amazing what you find. Consider all the options, and if you think about it, and somebody particularly who can't tell you, but either the staff or you think they may be having pain, you have to look head to toe for what that cause might be. Because if we can identify the cause, we can treat the underlying problem. And you can see in this cartoon, I'm stumped, we'll have to wait for the biopsy. So some examples of what can specifically cause or exacerbate pain with regard to musculoskeletal or joint disease. Believe it or not, angiotensin II receptor antagonists, biphosphonates, which we know about, calcium channel blockers, called Vidalol, cephalosporins, corticosteroid, donepezil, which many people think is totally benign. I always worry about GI symptoms, and potential pain, fibrates, which we know about, the fluoroquinolones, fluticasone, NSAIDs, who would have thought, pregabalin, who would have thought, proton pump inhibitors, SSRIs, and statins. So some we know, are these common? Probably not, but always things to think about. And sometimes patients will tell you stories where they started something and they really swear it made the pain worse. These are just some descriptions of pain for you. I'm not going to go through them, but just good reminders of what types of things we tend to see with the different types of pain. So when we're treating pain, it's critical, like with everything else, to make it person-centered. And as I said at the beginning, it really does need to be case-specific. And you really need to think about a comprehensive assessment and diagnosis of the pain. And I know I've said it probably 20 times. Actually, the pain is just nature's way of keeping you humble, but there's an underlying cause of it. Examples in which you can consider modifying the pain treatment. If pain is not resolved, you want to add behavioral interventions. I do this all the time with arthritis, whether people like it or not. Encourage weight loss because it makes a major difference. If you are carrying hundreds of pounds on those joints, it's going to affect you over time. Physical activity, physical activity, and physical activity. The problem is getting people to move enough so that the pain does get better. And often, many of us probably listening are to the point where even after this 45 minutes of sitting, you're a little achy when you stand up. Position changes are critical, whether it's a pillow, position people get left in bed are just horrible. Use distraction, and then ice, heat, and topicals are great. Times to think about possible dose reductions when we have identified the cause of the pain and treated it, when the pain is not responding to the current treatment, and the treatment's probably not worthwhile. And I always say to people, is this helping when you take it? And do a trial. Stop it and see if you notice anything different. If the person is having medication side effects, it certainly should be stopped. 6, if you're seeing signs of misuse or dependency, whether that's an opioid or not, it can be just a preferred personal dependency. I can't live without it. If the patient has skipped doses without adverse impact, you can usually feel pretty comfortable with stopping it. If the patient's pain is currently controlled and you haven't tried to stop it, because we'll never know. And then if the risk of continued treatment outweighs the benefits, then we need to think about reducing or stopping. Some other factors that may influence pain management: underlying medical conditions and prognosis. Obviously, if somebody is at end of life, we take a different approach to pain management where it really becomes a very high priority, regardless of drug side effects and any other issues. The characteristics of the pain and its underlying causes and contributing factors and addressing them. What the person's preferences are, what their goals are. Is it to eliminate pain altogether? Because then sometimes we need to renegotiate that goal and make it realistic. What's the highest level of function that that person can achieve, and have we done it? And can we alleviate pain so that that level can be achieved? I had a patient the other day in a house call visit where he absolutely was refusing to get up and the son was going crazy. And it was because he was having pain in his foot. And so I did initiate a drug treatment versus stopping when he wasn't taking anything. or yeah, I think maybe he was on some acetaminophen, but it wasn't cutting it. It's also things like the person may be having adverse effects that are interacting with pain treatment and they're analgesic. There may be other medications in the current medication regimen that are impacting the pain treatment, and other underlying conditions that may really tie our hands sometimes. Somebody have chronic kidney disease, there's only certain drugs you can use, you know the challenges. And then some of the biggest challenges, whether or not the person believes in behavioral approaches, even when it comes, and I haven't talked a lot about alternative medicine such as acupuncture, which is very helpful for some people. Again, it's what that person wants, what they're willing to try, what's available, what they can afford. And even some of the over-the-counter options can get pricey. And so it's working with people about what they can do. Setting realistic goals is critical. And I think it really is to reduce the intensity and duration of pain. And of course, identifying that underlying cause and treating it. And likewise with chronic pain, we want to focus on optimizing function, quality of life, and what is the minimal level of pain that person is willing to tolerate, and what is it they want to be able to do in their daily life. Addressing some behavior change is critically important. Diet, whether it's weight reduction or decreasing foods that are high in uric acid. Physical activity versus avoidance of activity. Medication changes, and use of pharmaceutical approaches. If you don't ask, you don't get. So it's really asking at every interaction about doing some behavior change. These are just some examples of what those behavioral interventions are. I go through some of the challenges, which I think we've talked about, but challenges for behavior change. And some of it really is just never giving up, making sure we continue to ask, getting people to engage in the activity, encouraging them, showing them role models, and decreasing unpleasant sensations to get them to do. You know, some people don't even like to put the creams on because they're uncomfortable. This is just an example of a care plan for pain management, and some examples of what surveyors look for when they're looking at your pain management, particularly your drug pain management. Rewards for your work are really better resident quality of life, better survey results, better feelings about care provided, less behavioral symptoms, and happier residents and families. So I'm going to turn it back to Chad.
Hello. Okay, I'm back. Okay, do we want to open it up for questions? Let me check the chat. If you want to use the chat function, if you have a question for Barbara, that'd be great.
Hey, Chad, this is Arif. Can I ask a question here?
Sure.
Thank you. Great session. What a great overview. I learned a lot. Thank you, Barb. Really appreciate it. What an important topic. You know, I actually, as you can tell, promote a lot of deprescribing and medication optimization in our facilities. And I actually talk to my many practitioners every week about giving them ideas. And I actually, one of the most pushback I get on a few medicines, allopurinol is one of them. And I try to tell, and I don't know if that's correct. I think it's correct what I tell them, but I would love some validation, I hope, is that I tell them, guys, come on, let's discontinue this 100 milligram itsy-bitsy dose once a day. They've been taking for years. Worst case scenario, they will get worse and their gout attack will put it back. But the fact that they have not had it for 4 or 5 years, they don't even remember when their last gout attack was. Let's just get rid of it. Do you think it's kind of a reasonable approach to use?
Totally. I mean, you have to try. And again, these are people in long-term care facilities where it's a different world. The diet is more controlled than what some people were doing before. And then you have to look at the bigger picture, you know, are they on diuretics? But if somebody's been on a diuretic and hasn't had a gout attack in 4 years, watching and waiting, absolutely. Especially if it's just they're on 100 milligrams just once a day. So I don't know if we have pharmacists who would disagree, but I certainly would give it a go.
Thank you.
No, I mean, as a pharmacist, I would just say that I'm empathetic to RF's plight, because I feel like we're always on that side of the table.
Stopping, encouraging, yeah.
Yeah.
And no one reads that consultant pharmacy note, right? Or has some reason.
You guys have gotten a lot better.
Yeah.
You've gotten a lot better.
And Chad, there's several questions in the chat.
Yeah, I'm gonna go to those. First question from Allison Bell. Any evidence for deprescribing biologic medications?
Yeah, I think, and that was to my point. I think it would depend on how the patient was doing on those and the cost benefit, you know, their tolerance, and then really their level of pain. You know, often when patients go out to a specialty area, if it's coming from a specialty area, the focus is just on that one disease, and you really have to take a bigger picture approach. If it was something that the person was willing to do, side effect profile, cost benefit, it's absolutely worth stopping. And, you know, you can always restart.
Okay, Lynn Wilson asks, do you have any favorite patient education resources?
So, I mean, again, depends on what patient population you're talking about, but I will say that my favorite would be, and it depends, there's a lot of really good ones from NIA, the National Institute of Aging. And also, I'm very involved with the Exercises Medicine group from really housed at the AMA, but we have a special section for geriatrics. And there are a lot of really good exercise programs and how to do exercise, for example, if you have arthritis and different pain approaches. So if you're thinking about those types of education, I would recommend those resources. And you can just go to those web pages. Or I'm not sure who asked the question. You can feel free to send me an email.
Great. Margaret Hurricks asks, have you had any success in reducing or de-seeing narcotics? And if so, what was your approach?
Oh, yeah. And I didn't go into, you know, the process of how you decrease dosages, but I have actually had to admit people to be able to do it, because some of it takes a lot of work to adhere to the process. And it's really just weaning down. And, you know, we can't always take away pain medication without replacing. And that was my point with decrease the drugs, but increase the behavioral. And that's the way we do it. So sometimes it's distraction, but it's really weaning those down. And yes, I have had many people I've gotten off of opioids. And as I said, even in this implementation work for the pain CPG, I am doing more deprescribing, and it's like you're giving him an opioid every morning, but he hasn't had pain in eons. And so we just wean down and decrease. So yeah, you got to give it a go. You have to talk to the person and make sure they're willing, but always give something back in return.
Okay, I'm going to go to Brian Isitz, who has his hand up. Brian?
Yes, thank you, Chad. Dr. Resnick, so nice to meet you finally, albeit virtually. I really appreciate your down-to-earth, practical style. And what I'd like to ask is, you briefly alluded to this in your presentation, that a lot of patients want to just use medication. So there's a pill for every ill. And what are some of the motivational tools you might work with patients to say, all right, let's change the paradigm from there's a pill for every ill so I don't want to have to be dependent or use medications, because like that one slide you showed has all the other options that are really can be effective. How do you change that orientation in some patients who just want to take medicines?
Exactly. And I didn't spend a lot of time on this, but those were my last few slides. So there's a lot of tricks of the trade I use. And it's basically, I come at it very much from what's called a self-efficacy based approach.
Mm-hmm.
And, you know, we all will do things that are easier for us to do. For everybody, it's easier to pop a pill in your mouth, especially when it's for pain. Hypertension, that's another story, right? Because you don't feel it. But it's getting people to believe that, you know what, icy hot is really going to help this. Getting them to do it to begin with. So I keep those types of things with me all over, and I'll slam them on somebody. Let them feel it, let them experience it. The other really big thing we need to do is, number one, always keep asking and encouraging. The same with physical activity, which is the best treatment for pain in many cases. I mean, because if you sat in a chair all day, you'd hurt like hell by the end of the day. So it's getting people to move and recognize, oh my God, I really do feel better. The other thing is we have to get rid of the other sensations. So some people don't like to put on an ointment because it feels yucky. So you work with them for the one that's going to feel the least bit yucky. If it's, they don't like to exercise because they get short of breath, they're afraid of falling, whatever it is, we have to address those problems as well. But some of it is, you got to keep asking. And even if somebody refuses the first time, the next time they come in, you know, let's talk about your pain again, and or your gout. You haven't had an attack in 3 years. How about if we try this? And, you know, maybe if you didn't have that drink every day, you wouldn't have a gout attack. So let's try and decrease the alcohol as well. I'm not going to take it away. I'm just going to try and decrease it.
Well,
So,
thank you, Barbara. I mean, because
those are some ways.
Well, thank you. It's kind of hard for us sometimes as pharmacists. We work with patients and they say, hey, I want to get you off medicines. They're a little confused because we as pharmacists, they think we want to give you more drugs. So we have that chance. So thank you, Barbara.
Okay, there's a couple more chat questions. Jason Renaud asks, when tapering allopurinol, how aggressively do you taper? For example, a resident is receiving 300 milligrams a day of allopurinol. Uric acid is normal and cannot remember the last gout attack.
So I don't know if our pharmacist wants to answer that. Clinically, I'd probably go 300, 200, 100. Bye.
I'll throw it out to the pharmacist since I haven't practiced in 5 years and I don't want to.
No, I'll take that, Chad. I do it with my nursing patients, so on not a lot of times because we've got a lot of them off allopurinol already. But let's say they're on 100 milligrams because that's a dose you just throw at people and leave it on it for a long time. Is that you might decrease them to 50 milligrams for a week. I might even go 50 milligrams every other week or 25 milligrams, but over 2 weeks and just by the end of the month, that should be totally off it.
Great. Thanks, Brian. Okay, Steven Stein asks, are there any regulations that would prevent a facility from having a referral to a physical therapist anytime a narcotic, NSAID, or other arthritic or other type of meds used for pain, example, anticonvulsants? What's everyone's experience with acupuncture and or acupressure in the nursing home setting?
Well, the last part of that in terms of acupuncture, if a family wanted to have somebody come in, it's just really getting somebody to come in And I have done that. I've even seen where acupuncture studies are done in these settings. And for some people, it's very effective for pain. So also some people have used it for swallowing. I think the first part of that question, I'm not sure if I understood it, but I think that it would be perfectly appropriate if you were doing a focused intervention to decrease opioid use and wanted to bring in physical therapy to optimize some movement. I think that would be perfectly appropriate. The physical therapist could certainly at least do an initial evaluation. Whether or not they'd be able to see the person for any period of time would depend on that person, their response goals, and everything else. But I'm not sure if I'm answering what the question was.
I think you got it. I think you did. Somebody else, Rita Amigdalos, who's a pharmacist, mentioned that most nursing homes don't want to pay for acupuncture. However, many in the community who do use it find it provides them some relief. So just an aside on that one.
Yeah, I don't think a facility would pay. I think the family would have to. Yeah. I mean, truthfully, for many of the alternative treatments, whether it's some over-the-counter something or other that an institutional pharmacy may not have, or families will often bring those in.
All right, there's 3 questions left, and I'm going to take them out of order because I think the last one is a broad question. But Colleen Hicks asked, 2 local rheumatologists recommend Tylenol arthritis as it is long-acting, allowing for better sleep and less frequent dosing for osteoarthritis. In their state, patients have to pay for over-the-counters out of pocket. That's more of a statement than a question. And then looks like Nettie Vora is asking, are there any studies based on mindfulness programs helping deprescribe? It has its own limitations, but just curious.
Yeah, I think those types of approaches and any cognitive behavioral therapy, I honestly did not talk about those that much because our challenge often in the populations that we work with in long-term care settings is that if there's cognitive impairment, you need to be really cognitively intact to do any of those. So I'm not someone who really pushes that in these settings. Certainly, I think more the approach of distraction is better than trying a mindfulness approach, particularly with pain management, because you could almost sit there and just focus on the pain.
Yeah.
Which wouldn't be helpful.
Okay, last question comes from Chris Darling. It's kind of a broad one. In some centers, some staff members also wish there was a pill for every ill. Do you have any tricks of the trade to bring them on board with deprescribing?
Yeah, it's the same. It's demonstrating to them that deprescribing works, that it can happen, that the person will actually be better in the end. And, you know, I do it for and with staff themselves. How many staff do we see who may also be experiencing significant pain, significant musculoskeletal issues? And for those of you who know me, I got a big mouth and I can't stop. So I will actually work with those individuals at the same time. And so it is sometimes helping them become believers, trying it, showing them, and just continuing the battle. I think the biggest problem we have as providers is to throw up your hands and say, well, they've been on it forever. Nobody wants to change. I'm giving up. And it's one of those things that we can't ever give up on, deprescribing, just like encouraging other health promoting behaviors.
Well, Barbara, thank you again. You're very generous with your time, and your information and the where it comes from your practice is just really wonderful. And we really appreciate you sharing with the group here. I want to also thank the Foundation for Post-Acute and Long-Term Care Medicine. They provide a generous support grant to support the D2D programming. To learn more about that, go to paltcfoundation.org. And then last slide. And stay connected to D2D. Visit paltc.org/drive, spelled out to the numeral 2, deprescribe, to sign up for email notifications about future D2D meetings, podcast episodes, medication optimization resources, and more. Thanks, everybody, and we will connect on the next D2D webinar.
Thanks, guys.
All right, thanks.